Brain health is a critical piece of your overall well-being. It underlies your ability to communicate, make decisions, problem solve, and live a productive and useful life. Because the brain controls so much of daily function, it's arguably the single most valuable organ in the human body. Hello, I'm Michael Himman. I'm the executive editor of Herald Community Newspapers and your host this evening for another Herald Inside LI webinar. And today's webinar, we're talking about brain health. Joining us this evening is Dr. Kimon Bekelis. He's the director of the Stroke and Brain Aneurysm Center of Long Island. Dr. Bekelis is a board-certified, fellowship-trained neurosurgeon with subspecialty training in minimally invasive endovascular neurosurgery. He additionally specializes in gamma knife radiosurgery and complex brain and spine operations. This evening, he'll discuss what you need to know about risk factors for both brain aneurysm and stroke prevention and treatment options for both. So, Dr. Bekelis, you probably don't get someone asking you this very often, but how are you feeling today?
Good. Thank you for asking, Michael. And thank you for the kind introduction. So this is a great opportunity to share what we do on a daily basis when it comes to our little aspect of brain health maintenance. And, we deal with strokes and brain aneurysms and a bunch of other diseases that affect the brain as far as the blood vessels that go into the brain are concerned. And so I'm going to share my screen and we're gonna go through this whole presentation. So, like you said, I direct one of the comprehensive stroke centers out here in Suffolk County. We are the only comprehensive stroke center in the South Shore of Long Island, which means that we have the ability to treat diseases of the brain, cerebrovascular diseases, stroke, brain aneurysms, pretty much any sort of difficulty and of any extent. And so any complexity is being treated here. These are my disclosures, and nothing I'm going to talk about today has much to do with those. I'm going to start with kind of one of the major topics of today, and really one of the major pillars of our practice, which is ischemic stroke. Ischemic stroke is the type of stroke where blood doesn't go to one part of the brain, and subsequently that part of the brain dies, and the patient develops weakness, numbness, and ability to speak, something of that nature. And it's a very mechanical problem. It's the result of decreased blood flow in that area, very similar to a heart attack, but for the brain. And when it comes to stroke, the biggest, I guess that the most important piece of information that I can give you and your viewers today is that detecting and identifying a stroke fast is the most important factor in guaranteeing that somebody is not going to have a deficit, or they're going to live a life free of disability and maybe save their life. And so the American Heart Association has come up with an acronym called FAST. FAST stands for face, arm, speech, time to call 911, to remind people how to identify a stroke. So really, like I like to say that us on the neurointerventional side, we're glorified plumbers. So what we do is open blood vessels when they're blocked from a stroke and allow the blood to flow back in there. But really, what makes the biggest contribution in the possibility of somebody making it out of the hospital without a deficit is their ability to detect that stroke. So keep that acronym very much in your mind. So other symptoms of stroke that commonly happen: numbness, confusion, blurry vision, loss of balance, and headache, rarely happen by themselves. They're typically part of this whole constellation of symptoms that we discussed with FAST. And so they always need to be considered when you're trying to identify if somebody's having a stroke. Strokes are an epidemic these days, and we're seeing more and more and more. And with projected numbers around 2025 that are going to reach about 1,200,000 patients across the United States. If you compare that to our other passion, which is brain aneurysms, those are steady and they're not really increasing in numbers because they're not affected by our lifestyle. But certainly our lifestyle and the risk factors that we're exposed to put us at much higher risk for ischemic stroke. And we're seeing more and more of that across the United States. So, like I said, what we do on our end, a lot of it has to do with fixing strokes, but the majority of the contribution to changing the outlook of brain health and stroke care is actually to prevent a stroke. And the reason is this, the statistics when it comes to strokes are fairly depressing across the world, actually. So 1 in 6 people will have a stroke in their lifetime, and from the about 15 million people that will have a stroke every year, only 6 million of them will not survive. Like we said before, it's a very, very common phenomenon across the world, with somebody dying of a stroke every 6 seconds across the world. And, I like this slide because, we have a lot of awareness when it comes to breast cancer, and rightfully so. But you'll see how many women actually die from stroke, a lot more than they die of breast cancer every year. Yet awareness has been limited when it came to stroke. And the reason was that we didn't have enough tools to address and fix stroke. So kind of awareness was fairly pointless if you don't have the tools to fix it. Nowadays, though, we have the ability to have very effective interventional treatments for stroke. Most recently, actually, and I'm going to talk a little bit about the procedures we do, but they've been, we've been doing them for a long time now, over 7 years, these new procedures, but when it comes to national media, they've received attention very much recently. And so if you look at our country, majority of the strokes happen in this area of the United States, and we call this area the stroke belt. The reason most strokes happen in that area is because the risk factors that contribute to the possibility of stroke are more common in those areas. You can see kind of those heat maps. You can see exactly how those are distributed across the United States. So risk factors like high blood pressure, high cholesterol, diabetes, and smoking across races, they are very much strong predictors of a stroke and general cardiovascular health. And so to prevent a stroke, what we call primary prevention, prevent a stroke before it happens, you need to be able to aggressively control these risk factors. And this diagram is called the ABCDE of stroke. Not a lot of, I'm going to start from B because there's a lot of controversy about aspirin. But when it comes to blood pressure, obviously needs to be tightly controlled. And everybody has a different target for a blood pressure depending on other factors. So obviously listening to your primary care doctor, that's going to really be, they'll be able to tell you what the ideal blood pressure for you is. Cholesterol, very important to control it. Again, the targets are very much individualized. Cigarette smoking is extremely hurtful when it comes to cardiovascular disease and stroke. Weight loss, very important for stroke. Diabetes, also same thing. Targets for glucose, very much individualized. Exercise, the targets for exercise are always very optimistic when it comes to guidelines. But really, what we do believe is that any sort of exercise, even a little bit, helps. When it comes to aspirin, it used to be a general recommendation. If you were over the age of 55, they would put you on a baby aspirin. Nowadays, this has been modified a little bit because aspirin has been found to slightly increase the risk of bleeding if you don't have any risk factors. But in folks that have had prior strokes or have had other more significant risk factors, you might receive a recommendation from your cardiologist or your primary care doctor to go on a baby aspirin. So based on these risk factors, when we see you in the office, we come up with a risk profile for you for stroke, and then we modify them, and we're trying to move you from the red to the yellow and to the green in terms of prediction. So now that's primary stroke prevention. Secondary stroke prevention is how do you prevent a stroke on somebody that has had a stroke already. And in those cases, you'll see, obviously, this is not to be comprehensive, but what I wanted to show is that pretty much everybody has to go on aspirin in these cases. And then depending on what other factors exist, we can also do interventions to minimize the risk of another stroke happening, either by operating on somebody's carotid or the heart or whatever else was the cause of the clot that traveled into the brain and caused the infarct. Again, the most important message when it comes to stroke is the speed of identifying symptoms really can make all the difference. And we use this this motto called "Time is Brain." It got coined by a neurologist who's currently at Loyola, and it is maybe the most important message of this conversation. So, how do you treat stroke? obviously primary prevention is important, but say somebody's having a stroke, then we come into play. The way you treat it is fairly straightforward. What you need to do is open the blood vessel up that's blocked. And the way you open it is either by a medication called TPA or TNK these days. There's other options, but a clot busting medicine that then will open the blood vessel, break down the clot, open the blood vessel, and allow the blood to flow back into the brain. Now, the challenge, and this is kind of pretty much how it works, comes through the IV, dissolves the clot, everything goes away. The challenge with this medication is that a lot of times this medication is not, folks are not eligible for this drug. The reason being either they've had a recent bleed, at which point they cannot be given a clot busting medicine, or they show up at the emergency room outside of the window, the time frame for administration of this drug. And that time frame is about 3 to 4.5 hours from symptom onset. So naturally, if somebody woke up with a stroke, they would not be a candidate for this drug because you really don't know when they were last well or when the stroke happened, because they were obviously sleeping. The last time they spoke to somebody was 6 hours ago. So obviously extremely, extremely challenging. So this medication ends up being administered to less than 10% of the folks showing up at the emergency room with a stroke, despite it being a great medication. So then mechanical thrombectomy came to be, which is an interventional procedure that allows us to treat stroke by removing the clot mechanically, and a lot more, the limitations and the restrictions for this procedure are a lot less. So obviously that gives us the ability to do it and have a much more profound impact. So this is what mechanical thrombectomy is all about. You have a clot inside the brain. You navigate the catheters, your catheters and wires, you go past the area of the clot, and either you deploy a stent to use it as a fishnet to grab that clot and move it out of the body, or you use suction devices or a combination of the two in an effort to take the clot out, allow the brain to perfuse again. And so that's the life-saving intervention that became standard of care about 7 years now. And multiple patients have been treated with this, and now it's receiving the attention it deserves on national media, with multiple articles recently in large platforms. So, this is kind of the timeline of stroke. 0 to 4.5 hours was the window you had with TPA, the clot busting medicine, and now we're looking into 6 hours initially in the first few studies for mechanical thrombectomy. And we've pushed it all the way out to 24 hours, which is obviously remarkable that, we're able to really treat patients that have had stroke symptoms 22, 23 hours before presentation. So stroke is a medical emergency all the way up to 24 hours, which has completely changed the field of stroke. This EMS has changed their protocols. They're very aggressive about bringing these patients to the right center. And obviously there's primary and comprehensive stroke centers like the Stroke and Brain Aneurysm Center of Long Island that can give you some treatments for stroke, or obviously every possible treatment for stroke. And to demonstrate how impactful mechanical thrombectomy is, I wanted to show you this statistic. So this is a statistic called numbers needed to treat. And numbers needed to treat demonstrates how many patients do you need to apply a treatment on to have one positive outcome. Obviously, the fewer patients you need to treat to see a positive outcome, the better it is. And you can see with mechanical thrombectomy in these studies that I demonstrated, it took 2 people receiving mechanical thrombectomy to have one with reduced disability. And so if you compare that to other interventions that, we know are very effective, and we use them without obviously thinking, like administering aspirin in somebody having a heart attack, you see you need to administer aspirin in 42 people to have one good outcome directly from aspirin administration. So you see how much more impactful mechanical thrombectomy is. And because of that, it really changed the field of stroke and changed what we do today and turned stroke into a very treatable problem. And so I'm going to give you a couple of examples from our own practice. And here, you see, I like to give examples of extreme ages to demonstrate that these diseases really do not spare young people, or they're not just the disease of the elderly. And so you got to be alert. Every time you see those symptoms, call 911, go to the nearest center. And so this particular lady's 36, young lady, and she presents 5 hours after stroke, and she has weakness on her right side. Her NIH stroke scale is 22. The NIH stroke scale is a scale that demonstrates how serious a stroke is. Anything over 6 is really, really serious. So she really is having a very serious stroke. She's 5 hours out, which means she cannot receive the clot busting medicine. So in a world where mechanical thrombectomy didn't exist, this lady would have not received any intervention. She would have had a large stroke, swollen in that area of the stroke, eventually needed hemicraniectomy, meaning surgery to remove surgically remove the bone, and then allow the brain to expand in that area. Likely she would have ended up in a nursing home, or worse yet, dead. And so instead, we did, you see these fancy maps that this is called the CT perfusion that tells us whether the brain is alive or not. And we got feedback from these studies that the brain is alive. You can go ahead and intervene. And in the bottom pictures, you see the blockage right here in this area. And then after we did the mechanical thrombectomy, remove the clot, blood is flowing again in the brain. So this girl went home 2 days later. Very different outcome as compared to a guaranteed horrible outcome that she would have had it not been for mechanical thrombectomy. So really, these interventions are changing the field of stroke. Much older patient, again, no age limit, downward or upward when it comes to these things. It all comes to functional independence, right? So this 92-year-old was extremely functionally independent. Again, large blockage right here. And you see when we open it, you see the flow up in the brain, complete resolution of the symptoms. Another more typical age of stroke, somebody in their 60s, you see, again, the CT perfusion, this dark blue area is telling us that there's limited blood flowing in that area because there's a blockage. And in the angiogram, you can see the blockage at the distal end of the carotid artery. There's no flow up inside the brain until you open it. And now you see all that flow. And this is what a blood clot that you remove from the brain looks like. In this case, we used a stent retriever or a stent to remove the clot. And what I find fascinating is that, there is immediate direct feedback from this patients to us in the angio suite. This is a procedure that's done under local anesthesia. There's no general anesthesia. Folks are awake. Mind you, just before the procedure, they don't understand. They're not following commands. Sometimes they cannot speak. They cannot move one side of their body. And so the second you remove the clot, in the majority of the patients, you see an immediate response. They start moving. They start talking to you, which is really fascinating. A lot of them are confused. They're saying, where am I? What am I doing here? But really, you take somebody who's incapacitated and they start moving. So now this lady that I just showed you, remember, she wasn't moving the left side at all. She couldn't really speak and understand us. This is immediately after the end of the procedure, and this is with her permission afterwards. But you can see we're asking her to lift both sides. So, this side wasn't moving at all. Now, all of a sudden, it's up in the air, which is pretty remarkable. A few seconds after we remove the clot, and then she's moving her legs. So really gets us going at 2 a.m. to go in the hospital and do the right thing. Now, another case that I find very interesting where stroke can kind of hide in the setting of other things going on. In this case, young lady comes in with a trauma, bad motor vehicle crash, a lot of broken bones. They're removing her collar. And as they're taking her collar off, she stops moving the right side of her body. She cannot talk. Obviously, being in a comprehensive stroke center like the Stroke and Brain Aneurysm Center on Long Island, protocols get activated immediately when that happens. And very quickly, through the appropriate protocols, we identify that she has a large vessel occlusion or a large stroke in the brain. And because of that, we take her to the angio suite, identify the blockage, open it up until blood is flowing into the brain. And then we found the reason why she had the stroke after a motor vehicle crash. And if you look at her carotid artery, you see this white area where contrast is not really going to, and that's a leaflet of the wall of the artery that's free floating inside of it, what we call a dissection. So her seatbelt, when she had the impact, resulted in a tear in the blood vessel wall, and subsequently that tear caused the dissection that formed clot that traveled into the brain. And on the way out, we placed a stent, and you can see from this, it went to this complete opening of the carotid artery without any issues, and that cured the cause of the stroke. And this is what if you can see this thin metal tube, mesh-like walls, this is what a stent looks like. Now, when it comes to ischemic stroke, obviously mechanical thrombectomy is the emergent way we deal with stroke, but often stroke comes from carotid disease. And carotid disease is one of the major reasons for stroke, and it's one of the major preventable causes of stroke. And so, building plaque in the carotid artery that can then break off, go into the brain and cause a stroke, obviously a very important mechanism by which you can cause a stroke. And there's three ways you can treat carotid disease when it becomes significant, and that level is around 70%, depending on symptoms or not, in multiple studies that have been done in the past. But one is a carotid aneurysm, where we make a skin incision and scoop the plaque out in its entirety, as you can see here on the left. And on the right-hand side is the more minimally invasive approach, where we go in through the groin, we navigate our catheters and wires, stretch open the blockage with a balloon, and leave a stent behind to keep everything in place. That's transfemoral carotid artery stenting. And then there's a hybrid of the two that's fairly favored these days when it comes to the treatment of carotid disease, and that's called TCAR, or transcarotid artery revascularization, where we make about an inch-long incision right above the clavicle, and we're reversing the flow. So while we're putting a stent, we can remove all the debris from the body. And so this is kind of what a carotid endarterectomy would look like. Obviously, big exposure, removing the plaque and cleaning everything out. Whereas a stent, obviously a lot more elegant. You don't have to make big incisions. You can do this really minimally invasive. You see the blockage right here that has caused a stroke. And then you see after breaking up, stretching open the blockage and leaving a stent behind. Again, same thing, thin metal tube in that area. So, we've developed the program in a way where we can treat stroke when it happens. We can prevent stroke either surgically or medically. And so the gamut of ischemic stroke, we really aggressively treat. But obviously, the ideal scenario is when we prevent a stroke through good risk factor control. And a lot of that responsibility lies with the primary care doctors, the cardiologists, and obviously the patient's adherence to their recommendations. So that's one type of stroke, the limited blood flow to the brain. The second type of stroke is the too much blood in the brain type of problem, where you have a blood vessel rupturing inside the brain and causing a hemorrhage. That's called a hemorrhagic stroke. And a common cause of hemorrhagic stroke, other than high blood pressure, is brain aneurysms. So brain aneurysms are balloons on the side of the blood vessel, for lack of a better term, and they're very dangerous. When they rupture, about half of the patients die right away. And from those that survive, only about a third will make it out of the hospital without any issues. So really, we try to get ahead of the curve and treat those problems before they become significant. And the way, the way we treat those aneurysms, I'm going to talk about a little bit, but I want to show you a video from the Lisa Colagrossi Foundation, which is one of the national foundations on brain aneurysm awareness that we've partnered with. And they've supported a lot of our activities locally. And if for those of you who don't know, Lisa was a reporter. She was on TV. She got off TV and ruptured her brain aneurysm, died, and left behind her husband and her kids, who obviously through tremendous tragedy, her husband found the strength to turn this tragedy into something very productive for other people. So he created this foundation. He spread awareness for brain aneurysms. He has a lot of connections with celebrities and other folks who have the platform to get the word out and talk to people about brain aneurysms and speak about prevention and awareness, which again is the biggest battle when it comes to these things, is awareness. And so one of their first PSAs that was released, I'm going to play for you here, that talks a little bit about brain aneurysms.
A brain aneurysm doesn't care if you're busy. It doesn't care that you have important meetings. It doesn't care that you have to drop your daughter off at ballet and your son off at soccer practice. And if you ignore the warning signs of a brain aneurysm, you'll realize too late that the meeting wasn't that important. No meeting is. That you'll never see another soccer game, and that your daughter won't see you in the audience at the big recital. So if you suddenly experience the worst headache of your life, sharp pain behind your eye, and blurry vision, don't ignore it. Seek immediate emergency care because your family is counting on you to take care of you. The Lisa Calagrassi Foundation, shedding light on brain aneurysms.
So, I think it really drives the message home of, these are events that we have very little control over if we don't know that the aneurysm exists. And when they do happen, they'll change your life forever. Very few people will survive them. And so we have the ability these days, like I'm going to show you, to treat brain aneurysms before they become a problem, really, really in a minimally invasive way without any substantial impact on the patient. So it's really important that we understand that. And when we are lucky enough to identify a brain aneurysm, we aggressively address it without needing to be in a situation where, we have a catastrophe. And now these are the ways we treat brain aneurysms. There's the classic way where we make a skin incision, take a window bone off and put a clip at the neck of the aneurysm. That's called clipping. It's a fairly uncommon way to treat aneurysms these days, fairly invasive. Most aneurysms these days are being treated through the groin or through the wrist. We navigate our catheters and wires all the way up into the brain and find those little balloons, catheterize them and deploy platinum coils in there to clot them off, or use stents across their neck to seal them off. And so these two types of interventions have been extremely effective, and patients do great. They come in, they get a needle stick in the groin, the brain aneurysm is fixed, they go home the next day. So a couple of examples, you can see here a 27-year-old woman with a ruptured brain aneurysm. She was very lucky. She advocated for herself. She had a horrible headache. EMS was not very hot on taking her to the hospital. She demanded she went to the hospital, and she did. And this brain aneurysm was discovered really, really small. In her case, was about 1.2 millimeters ruptured, blood everywhere. And you can see it here. And after we put a tiny nanocoil, you don't see the aneurysm anymore. So seal the aneurysm. She did great. She's I think 5 years out now from her rupture. She was a kickboxer. She still does it. She's really good at it. And, she was lucky enough that this didn't impact her. But obviously you want to have that treatment before it ruptures, because statistically you don't have good chances after a rupture happens. Now, in this case, 58 years old, double vision, aneurysm hasn't ruptured. You see this aneurysm a lot larger, shaped like a heart. You see it again here. And then you can see it in the 3D, how big it is. And the reason she had double vision, you see this waist here on the aneurysm, is because the aneurysm was pushing on the nerves that controlled movement of the eye. And that's why she was having double vision. And now you see the coils inside the brain aneurysm. And those completely obliterated the aneurysm. See the little tiny catheter leading up into the aneurysm, really engineering miracles to be able to deliver these devices into the aneurysms. Another lady, you see very large aneurysm. We placed, in her case, we did not use coils, but we used this stent. You can see this mesh-like tube right here. And what happens is the stent progressively clots off the aneurysm and seals it off entirely. It's a curative procedure. You see 6 months later, there's no aneurysm anymore. Really dramatic interventions with very minimal impact on the patient. So, really completely changed the way we do what we do with brain aneurysms and stroke. And like I said, we're the only comprehensive stroke center in the South Shore of Long Island. Really an honor and responsibility for us to deliver this care and deliver good care every single time. And a lot of the patients come to us directly from Good Samaritan Hospital, St. Catherine, St. Joe's, multiple hospitals, other hospitals that are bringing patients. We have transfer protocols that get activated every time. We have a very large team. People are on call all the time. They're in the hospital. If they're not in the hospital already and it's 2 a.m, they're going to be there about 10 minutes in. It's really, really fast. The process works really fast. And, the way you do it is you have phenomenal infrastructure, and new biplane angio suite, a second one being built as we speak. The first neuro ICU and step-down unit in Suffolk County, that was built about 6 years ago, really was able to support this program. And then a lot of new nursing, stroke folks, and obviously technologists, mid-level providers, and a bunch of other folks that really made this program a reality. Now, we do a lot of research and we try to identify ways where we can help our patients, not just by direct care delivery, but also by understanding the diseases. Our paper was the one published in JAMA several years ago that demonstrated that patients at the time should go. It was based on 850,000 patients across the United States with real travel times. And we demonstrated that folks need to go to the nearest primary stroke center at the time to really receive the best care, not just the hospital that's not certified. These days that we have comprehensive stroke centers in the last 3 to 5 years, obviously this data to be extrapolated to that, it makes sense to go to the closest comprehensive stroke center where you can receive care for every single process that involves the brain versus just a small aspect of it and then get transferred out. The success of the program has been based on 4 basic pillars. Clinical care being a very important one. I showed you what we do. Obviously, having good results is what really keeps a program afloat. But then research is important. We do a lot of that. Try to really identify larger problems and serve our patients through changing protocols and policies at a different level. Education is key. Folks being able to understand what a stroke is and identify a stroke is going to bring these patients to the hospital faster, and it's going to make a difference in their lives. Again, we're glorified plumbers. We can always open the blood vessel. If the patient is not in the hospital on time, it doesn't matter what we do with the blood vessel, the brain is already dead. So the patients really have a lot of the responsibility and their families, frankly, to come to the hospital on time. And education is what we're doing today also. So, going out there and talking about these issues to the general public or EMS is really key in getting the word out. And I think last but not least is quality improvement. So we have a phenomenal quality improvement team that every stroke case that comes through the center gets reviewed the next day. There's a lot of emails that go out, a lot of phone calls. If there's any issues, all our times are being benchmarked by the Joint Commission of the Department of Health in New York. And so if our performance is lacking in one particular time, say door to CAT scan or door to medication, we identify what the issue is and try to fix the problem systemically. And this approach has really served us well. And we've had tremendous impact over time in changing how things work, especially in one of the busiest emergency rooms on Long Island. So as I said, education is important. So you'll see us out there. We're constantly trying to spread the word. Like I said, spreading the word is really what makes a difference. And we do believe in supporting survivors. And I think we have one of the most vibrant support groups on Long Island. I'm going to talk about it a little bit. And we're also supporting survivors events. And this is the National Stroke Association, American Heart Association walk. It's been going on since 2017, and we are a sponsor of that event now for 6 years. Like I said, our support group, really, really vibrant. It's one of a kind in the South Shore of Long Island. We're not only welcoming our patients, we're welcoming patients that have had strokes and did not receive care by us in other locations, and also their families. Families are important. A lot of times the patients don't want to come, but the families need the support. So we're open to anybody and everybody. And obviously we have strong national support by the Lisa Foundation, among others. This is one of our days where a support group and a bunch of our patients there. And the strong work of this team, and it's a very large team. I'm obviously leading the majority of these efforts, but for me to be successful, there is hundreds of people behind me that make things happen. And so they've all been recognized again and again and again, and they're still being recognized every year with multiple awards by the American Heart Association, the Long Island Elite, the National Stroke Association, Get With the Guidelines Awards, now on our most recent iteration, the Joint Commission Comprehensive Stroke Center recognition, and several other awards for Best of Long Island and recognition by the patients themselves. We're in social media. You'll see us on Facebook, Twitter, and LinkedIn. We're out there spreading the word. Like I said, awareness is largely what we do because that's going to make the difference for our patients. And so obviously you can reach out to us at any point through social media. You can reach out to us through our website, which is strokecarelongisland.com. And you can find all the information about us there. And obviously we're always available to help with education, but also take care of patients. Michael, thank you.
Fantastic, doctor. So much information there too. It's amazing that the terms, the conditions we see, strokes, aneurysms, they're definitely not new for a lot of us. Like we know, we've heard of them before, but really probably never really heard in such detail and just how much is there. And I'm sure you're like scratching the surface of that. But I think that one thing that especially when you're keeping an eye out for potential stroke, that sometimes we ignore because we don't know what to look for, but also we might ignore it because we say, hey, there's no way, you're too young. Like, let's say, I'm kind of a young guy, but I'm just as capable of having a stroke as someone who might be older, correct? I mean, we can't ignore if I'm showing some of those symptoms.
That's exactly right. We see strokes in all ages. We see strokes in kids. They're uncommon, obviously, in kids, but the problem is if you miss the signs and symptoms and you don't render the appropriate care in a child that's having a stroke, the impact will be dramatic for that child. There's statistics, it's uncommon, right? But if it's you, it's 100%. So you can never miss the signs and symptoms of stroke at any age. And if you're concerned, if there's, like we said, face, arm, speech difficulties, call 911. The worst thing that can happen is you spent a few hours in the emergency room and folks determined it was a migraine, it was a seizure, it was something else that caused those symptoms or nothing at all. It's much better than having a life of disability, substantial disability, or sometimes even death. So early, time is brain, I think, is the most important message. And so age is fairly irrelevant when it comes to these things. Nobody's immune. And so we should be very aggressive at identifying symptoms and seeking medical attention.
Yeah, and I think I think if people take away anything, that's probably one of the most important aspects of that is time. I mean, once you start seeing that the clock's ticking, or it's already started ticking in many cases, and so the faster you respond to that, your better your chances are of avoiding disability, avoiding death, in particular. But then how do we make sure though that we're not? I mean, I get headaches all the time, for instance.
Right.
I mean, myself not making the headache worse because I'm anxious, like, oh my goodness, what if it's an aneurysm? What if it's I mean, I know we have like the symptoms to look for, but sometimes you're like, oh no, I don't know, it's so hard to differentiate sometimes symptoms of one thing from symptoms of something else.
Right. And you're right. And I'm going to make it very clear for you. When it comes to stroke, the symptoms are, you can miss them, right? If you're weak, not tired, the arm is not working, the leg is not working, the face is drooping, or speech is garbled, or completely aphasic, words are not coming out. You have to seek immediate medical attention. When it comes to headaches, things are a little bit more murky, right? And headache is a symptom of aneurysm rupture, possibly, but it's not any headache. So you have a history of headaches, you're having headaches all the time. Your run-of-the-mill headache, even if it's fairly bad today, is not really the aneurysm headache. What the aneurysm headache is like is the worst headache of your life. It's like somebody hit you in the head with a hammer. It comes on within a split second. It goes from 0 to 100 in that split second, and it's unmistakable. So, every patient that we've had with a brain aneurysm that has survived and has come for care emergently, they've said, this headache was different. This was the worst headache I've had. It's always the worst headache of somebody's life. It's almost very stereotypical. So if somebody has headaches, chronic headaches, and it's one of those, not to worry. But if you're worried about one particular headache, if this is different, seek immediate medical attention.
Now, for aneurysms, is it so? I know not everything presents the same way, but are there, is it more often than not that aneurysms can be asymptomatic, or are they always symptomatic in some way?
No, that's a very good point. Almost always they're asymptomatic. So when an aneurysm ruptures, you get this horrible headache, and obviously very much life-threatening scenario. But majority of aneurysms are asymptomatic, and they're discovered in the setting of something else. Somebody's dizzy, they get a blood vessel scan, they see an aneurysm. Somebody has a car accident, they get a blood vessel scan, they find an aneurysm. Those are kind of what I call a blessing in disguise, because some of those aneurysms are sizable enough to pose a threat, but certainly haven't caused it yet. Therefore, now's the time to fix them. When you keep somebody in the hospital for a day, send them home without any issues with a little needle stick in the groin, versus situation where you have blood in the brain everywhere. There's a very high risk of death from that in and of itself. And then if you survive that, then you have to come to the hospital, get treated, likely get a drain inside the brain to drain the blood, multiple operations, long stay in the hospital, at least 2 to 3 weeks. And from those folks, only a third will make it out of the hospital without any deficit. So really challenging scenario. So if you're one of those lucky few that have obviously in an ideal world, you don't have a brain aneurysm, but if you do, and you're one of those lucky few that have a scan and identify a brain aneurysm, that's a blessing in disguise. We can do something about it, and the majority of the times in a very minimally invasive way, and prevent catastrophic event down the line.
Now, I noticed that when you talk about brain aneurysms, I notice that you talk about, you say brain aneurysm, you don't just say aneurysm. Are there other types of aneurysms? I know you focus on the brain mostly, but are there
Right.
are they just
There are. Yeah, so wherever you have a blood vessel, so your entire body, you can have a brain aneurysm. So you can have an aneurysm.
Yeah.
An aneurysm is a weak spot in the blood vessel, right? So you can have an aneurysm in your abdominal aorta, in your belly. You can have an aneurysm in your chest, in your thoracic aorta. You can have an aneurysm behind your knee, in the artery that's behind the knee. So you can have aneurysms everywhere. And there's different indications for treatment, and there's different guidelines, and they're treated by doctors that deal with the blood vessels of that area, vascular surgeons, cardiac surgeons, thoracic surgeons, or neurosurgeons in my case. But there's different guidelines. There's no correlation between having a brain aneurysm and having a body aneurysm. They're kind of independent. So, if you had a body aneurysm, your risk of a brain aneurysm is not higher. We've done several studies on that, but certainly really, aneurysms are very prevalent. Yes.
Are they just as dangerous though, like a body aneurysm? Is it? I mean, is something, if you feel you might have that, you should get it addressed right away. I'm assuming you shouldn't mess around with that if it's
Yeah, so same thing, when an aneurysm ruptures anywhere in the body, it's a medical emergency. And it's time is of the essence, very much so. If it's detected non-invasively, then it's a little bit of a different conversation. Again, different areas, different guidelines for treatment. Some you can watch, some you can treat. In the brain, we have there's several aneurysms we watch, we don't treat, and some others that we treat. But it all depends on size, morphology, location, age, other risk factors, family history. So these are important things that we consider when it comes to brain aneurysms.
When we talk about preventive health, we typically talk about going to a doctor, getting your annual checkup. Sometimes you might get an EKG, for instance, to check out your heart. But why don't we include things like brain scans or something that might help us detect if there aren't aneurysms? Or is that just, or it's just not really possible to do that way? You can't just randomly look for them.
Well, it is. It's very possible. The issue is this, the way we detect brain aneurysms in terms of screening would be through an MRA. An MRA is an MRI specifically looking at the blood vessels. It does not have contrast. It does not have radiation. It's a very good scan. And if it's very sensitive, it'll pick up almost all brain aneurysms, even if they're 1 or 2 millimeters, really small. Challenges are obviously that it all comes down to cost and insurance coverage. So because it's a fairly rare disease, I think it hasn't been deemed as mainstream to scan people with MRAs. Now, we do scan people preventatively with MRAs when folks have a strong family history of brain aneurysms, have somebody in their family with a ruptured aneurysm. So these are having headaches and a ruptured aneurysm. So these folks, we can easily get them navigated through insurances and get them a scan. But for the general public, I think it's a very challenging scenario. And there's a lot of advocacy efforts that are going on to make MRAs more mainstream. And the argument is that obviously it might be relatively rare, it's not extremely rare, brain aneurysms are fairly common still, but when they do rupture, their impact is so profound that to some extent you cannot afford to miss one. And so it does make sense. So, a lot of the organizations I mentioned, like the Lisa Foundation, some of their main advocacy efforts focus on getting MRAs more mainstream. And one of the initiatives we have at the Stroke and Brain Aneurysm Center during September, which is Brain Aneurysm Awareness Month, is for 4 weekends of that month, we offer free MRAs for people who want to get screened at the center. And so I think, it's you're hitting the nail on the head. And, obviously this is a story that hasn't been written yet, but it's certainly one of the forefronts in the battles that we're giving to minimize the impact of this disease by preventing it and identifying it early.
So is the assumption then, I do apologize if I'm repeating something from the presentation, but is that the assumption that a lot of times these aneurysms that they develop over a longer period of time, like it's not that just suddenly my vessels decide to act up and suddenly create an aneurysm, right? Some of these are longer.
Right. It's generally, you're genetically more prone to develop a brain aneurysm, not in the sense that it runs in the family always, but more than, your genes put you at higher risk. That doesn't mean that you were born with an aneurysm. Most aneurysms develop at some point in somebody's lifetime. They're not congenital. They're not since birth. But it's really tough to tell when an aneurysm develops if you have a single scan of somebody's brain showing a brain aneurysm, because you've no idea when it developed. And also the rate of growth is different for every person. You can have an aneurysm that stays the same after it reaches a certain size, or you can have an aneurysm that enlarges really fast. So it's kind of tough to tell which one is which. And so if you decide to monitor a brain aneurysm, monitoring needs to be extremely close, typically every 6 months to a year, depending on size, with MRAs to prevent a rupture or to prevent a change in size that would make it now more appropriate for treatment. And if you treat a brain aneurysm, again, you have to take care of it and completely treat it so that it's not posing a threat for the patient.
Yeah, and that's a pretty complicated process, as we saw, and I want to jump back to strokes here really quick, but before I do that, so is that to say that every aneurysm is deadly, or is it possible to not be treated for an aneurysm and somehow come through it?
So not every aneurysm is fatal, that ruptures, that is. About 50% of the patients, though, will die right away. So 50% will not make it to the hospital. Often folks believe it's a heart attack because it's so immediate, but then on autopsy, they identify blood in the brain, and that shows obviously it's a ruptured brain aneurysm. And so from that 50% that survives the initial rupture and makes it to the hospital, only a third will make it out of the hospital without any deficit. Another third will have some sort of stroke-like residual symptom, weakness, numbness, inability to speak, and the rest, the other third, will die. So that's from the 50% that survive the initial impact. So really, a brain aneurysm is a very, very severe event when they rupture, but people do survive, and we have several survivors with brain aneurysms that we treated and they've done well. Others that have had deficits. It's a very problematic disease, but these odds are, as harsh as they are, if you treat a brain aneurysm before it ruptures, all this goes away.
Yeah, and that's where treatment and identification of it is so very important. So jumping back over to strokes really quick. A lot of times we talk about, that you can prevent strokes, or maybe you can reduce your chances of strokes with blood thinners and such, like take a Tylenol or an aspirin or something. Can't remember which one of those is the blood thinner. How true is that? Is so is it significant? Is it a significant impact on potential strokes or treating potential of reducing stroke?
What is the significant impact?
Yeah, by taking a blood thinner or some sort,
blood thinner.
Type of blood thinner.
Yeah, so it all depends on the type of stroke that you're treating, right? So if or the reason for the stroke that somebody had. Generally speaking, when somebody has a stroke, they go through an extensive workup into their carotid arteries, into their heart, into the blood vessels of the brain to see if we can find the reason for the stroke. If the stroke came from from a blood clot in the heart because of an abnormal heart rhythm like atrial fibrillation, AFib, these folks would go on a blood thinner. These folks would go on anticoagulation, and that will prevent another stroke from happening because no more clots are going to form in the heart that will travel into the brain under that blood thinner. However, if the stroke, say, came from the carotid artery, the answer might be surgery to open up that blood vessel, like I showed you. If it came from blood vessels in the brain, the answer is typically antiplatelet medications, a form of thinning the blood. Often, and by often I say something in the realm of 30 to 40%, we cannot really put our finger on why the stroke happened. And you look around, you do all the standard tests, and there's no real clear indication where the clot came from. And in those cases, we found that putting somebody on a baby aspirin really dramatically decreases the risk of stroke to back to normal levels. So all in all, I would say when a stroke happens, blood thinning is the way to go. In the majority of the cases, preventatively, we don't obviously put folks on blood thinners. Some folks that are high risk might be on a baby aspirin, but that's pretty much what we're doing.
So when we talk about risk, by the way, is there a way, I know we talked a little bit about, risk, genetic disposition a little bit, but is there a way to know if somebody is at a higher risk for a stroke aneurysm? Like could you say, oh, look at me, I'm older than 45, don't exactly weigh the right weight that I should probably weigh. Right. Maybe, maybe somebody smokes a cigarette once a day or something. I mean, are there risk factors, or is there a way of determining if somebody might be more at risk for a stroke or an aneurysm than somebody else?
Yes. So when it comes to brain aneurysms, I think it's kind of more straightforward. There's not a lot of risk factors that put you at higher risk other than strong family history and smoking. So these are the two risk factors that we know will put you at much higher risk than anybody else. When it comes to stroke, folks that have high blood pressure, high cholesterol, diabetes, and are possibly smokers are also at much higher risk. Also, family history is important there, and body habitus. So the folks that have those risk factors really at a much higher level of risk of getting a stroke.
So now, and I'm sorry if I'm jumping back and forth between
No,
stroke,
of course.
but but I'm trying to field some of the questions that we got from people who registered when they came in. So let's say that you suffer, like you feel like you might be suffering from, like some of the symptoms of, like, say, a burst aneurysm. How do you know which, like, let's say you're going to rush to the hospital yourself. How do you know which hospital to go to? Like, how do you know which hospitals are equipped to handle this, or are they all equipped to handle something like that?
That's a great question. So, not everybody's equipped, and that's why you see there is definitely, there's different levels of classification and of recognition through national organizations such as the Joint Commission or local, like the Department of Health. And it's difficult for the general public to know that the Stroke and Brain Aneurysm Center in Long Island is a comprehensive stroke center and another place is not, right? But what happens is EMS is the link between the patient and the facility. So that's why in our recommendations, we don't say drive to the nearest comprehensive stroke center, but we say call 911. Because 911, there's protocols that us on the back end work with the different players and different shareholders to identify the best protocols for transfer. So once you call 911, you will be transported based on protocols to the appropriate facility. And obviously, if you're right next to a primary stroke center, most likely they'll take you to a primary stroke center because it's right there, and then transport you to the comprehensive stroke center. But, that's kind of how it is. EMS really has that burden and responsibility to identify the right location.
That makes a lot of sense. I mean, they're the professionals when it comes to that, and obviously better equipped. But then, of course, you have, those crucial minutes, and it's just minutes, but they still have to be able to get there. Unfortunately, we don't have the technology to beam anybody anywhere. But what is there anything you could do in the meantime? So let's say that you're suffering from a stroke or an aneurysm or anything, or if you have a family member or somebody close to you that's doing that, and you're waiting those few minutes for paramedics to arrive, for ambulance to arrive. Is there anything you could do even in those crucial minutes? It seems like every second counts.
That's exactly right. And, contrary to a heart attack where you give somebody aspirin and, that's kind of the well-known recommendation of what to do. When it comes to stroke-like symptoms, there's nothing you need to do. Just call 911 and go to the nearest hospital. The reason being, we have no idea when you're having stroke-like symptoms, whether you have an ischemic stroke, which means blockage in a blood vessel, or hemorrhagic stroke, which means bleeding in the brain. So in one, the treatment is blood thinning. In the other, the treatment is stop the bleeding. So we cannot really recommend taking aspirin. You might be having bleeding in the brain. You'll increase your risk of more bleeding.
You just make it worse then, right? If that was the case. So
Exactly.
that's actually really interesting because in all honesty, I would probably just think like, oh, well, this is a stroke, blood thinners, right? But
Right.
I would never thought about like, what if it's the stroke that, that it's, that's the last thing you want and you can just make it worse, that you could have exacerbated.
Exactly.
So just don't do anything, just wait.
Just wait for 911. Yes. But obviously it sounds really simplistic, but it's so impactful. Time is important. So the quicker you make that phone call, the higher the chance of survival is. Every second results in dead brain cells. And so, the quicker you get the process going, the higher the chance of survival without a disability.
And we're near the end of our discussion here, which is sad because there's so much I can still ask. But if you were to suffer from a stroke, and you were able to recover from it, how long does it take to recover? And could you actually fully recover from a stroke?
You can. It depends on the extent of the stroke, right? And so you might recover from a stroke immediately when, you come in, you get the clot busting medicine, symptoms go away, you're perfect. Or you might, I might go in through your groin, remove the blood clot, and you're doing great. But often, despite those interventions, you might have some sort of small deficit, a little weakness in the arm or whatnot, problems with speech. The majority of the recovery happens within the first 6 to 12 months. And unless it's a catastrophic stroke with extensive amount of brain loss that cannot be salvaged because we don't, we're out of the window, or, the brain is dead already by the time the patient comes to us. In these cases, obviously, recovery is going to be minimal, but smaller strokes, even if the deficits are severe, most of the times they do very well over time. And the most important intervention in these folks is very aggressive physical therapy, occupational therapy, and speech therapy, if that's what they need. But those are the interventions that are really going to change the outcome. You have to retrain your brain, retrain your nerves and your muscles to really get back into doing everything. And so that's the way to go. And like I said, the majority of the recovery happens within 6 to 12 months.
Excellent. I mean, and thank you so much for sharing all of this valuable information to our audience, Dr. Bekelis. If someone is making an appointment or reaching out to you, how can they reach you?
So there's a couple of ways they can reach us. Obviously, I think our website has all the information. That again is strokecarelongisland.com. When they're trying to call us for an appointment, obviously they can always call our office at 631-983-7072. And like I said, they can reach us in social media. But obviously, when it comes to medical care and seeing us in the office, I think the best avenue would be call our office, or our website has all the information on how to reach us and see the work we do.
Excellent. Any other parting words before we say goodbye?
No, thank you for the opportunity. I mean, this was a great opportunity to do what we do, which is spread awareness, and hopefully one person at a time change the outcome of this disease. Excellent. And again, thank you so much. For more information or questions about Herald Inside LI webinars, feel free to email us at insideli@liherald.com. That's insideli@liherald.com. I'm Michael Hinman. Thank you so much, Doctor, for joining us. And thank you again, and have a great evening. Thank you so much. Take care.